it's something about the way that information is delivered then? So perhaps it's too much all at once, because we talk about people wanting a lot of information, but do you want it all now, or is there opportunities, are there best ways of delivering information so that there are manageable sizes and you can go back to communicating within the service that you're involved in?
Well, yes, I think if you get a DNA test result, it's like you get to hear you have cancer. And giving a lot of information at that time doesn't work, because you are so stunned, so startled by what you hear that you don't even hear the information. So I think the information, the real information, has to come in time. So maybe you should organize some follow-up session after some time after test result, so that the person can let the information really come to itself.
And likewise, perhaps also who delivers the information, that you have had time to digest the information and then perhaps want to speak to somebody else in a similar position, perhaps?
Yes, definitely to speak to somebody else in a similar position. I think this is one of the most important things of all, to know that there are other people out there who've been through this before you, and can perhaps help you. Again, in Denmark, there's always something that's organised, but we have there's what you would probably call a blog on the internet, where people can write in. And I understand that they get up to between 600 and 700 letters every month from people who have problems with breast cancer, and particularly with genetic breast cancer. So this is one way of doing it. They're mostly young women who find out that they've got the genetic problem, and they have their own lives to live. They're not like the rest of us who've been through it, and our children are growing up and grown up. I think this must be an important thing that you found also, the younger women have more problems than the older women.
No? Well, yes, certainly younger women, if they have breast cancer, are much less able, strangely enough, to cope with it than our frail elderly patients that we worry about. It's actually the young women who, in fact, have more maintained high anxiety levels throughout. Maybe it's because older people tend to discount for age and stage. You know, they're much better at thinking, well, you know, in comparison to Mrs. Smith down the road who had a stroke, at least I can still walk to the post office, to the shops or whatever. I think actually the way in which people receive information is an enormously varied thing, and the skillful communicators develop a sort of nose twitch about how far to push different amounts of information. I think that information about genetic sort of risk and assimilating the implications of that, the consequences of taking different sorts of actions, can only be seen as a process. But I probably differ slightly about the fact that once you've actually confirmed that somebody's, you know, got the gene, that you then say, but come back next week and we'll talk about it. Because what does that person do? They go home thinking, oh my God, I've got the gene. What's going to happen? So I think it's actually quite important to actually give people information, knowing that they won't take it on board, lots of written information, access to the sites, the trusted sites though, because actually that's perhaps something we ought to discuss, which is that there's a mass of really bad misinformation out there that people can access. And my worry would be that if you said to somebody, oh, I'm sorry, but you are at risk, but, you know, come back next week and we'll talk about what to do about it, they're going to be so anxious they'll go on to all these other sites. We have to give them something else to take away, knowing perhaps that they won't take it all on board, but giving them a clear structure, a time frame when they can come back and discuss with others what's going on.
I think the important thing in terms of information is for people who've had a genetic test, for some people it's a diagnostic test. They've got cancer and they're being told the cancer is because of the mutation in the BRCA gene. So they've had cancer and this confirms the diagnosis. For other people, they go for a pre-symptomatic test. So they're currently well, but they know that cancer runs in their family. So it's before they have any symptoms, and there's perhaps different sorts of information needs that people have. And we also see cancer genetics, the health service, as very different to other healthcare services. It's not like you break your leg, you go into hospital, you get it fixed and you're discharged. Once you come into a cancer genetic service, you should be there for life, because it's a journey really on cancer genetics, and your information and support needs change at different stages through that journey. You might hit an age, for example, where your mother or your grandmother had cancer and you might have different information and support needs. So for us, it's really the journey that people are going through when they're talking about inherited cancer that is sometimes a bit different from spontaneous cancer.
That also applies to the information you give people to take away. And for some people, just the fact that there's a lot of information, or that some of it is difficult to understand, or that it's, or whatever, is in itself a whole extra piece. And I think there's a great deal to be done still, certainly where I live, about simplifying information, about making it very clear, about staging it properly, about explaining language.
Of course we are talking about breast cancer, but it's quite a difference if you are young and you have breast cancer, or if you are young and you have not had breast cancer. And especially with the genetic predisposition, there's a whole group of young women who have the predisposition and who didn't have cancer. And that group is growing, I think. That is our younger generation, and they are seeking for information because they have to make decisions for the rest of their lives. And there are very important decisions. And the issues are changing. They have to make decisions about family planning, about
maybe they won't have cancer.
No,
so
but they have a high risk only.
They have a high risk, but maybe they are good all the life through.
That's how they interpret their risk.
Can I add a couple of points of information? Even if you're a gene carrier, I think your risk is between about 70 and 85%, but there are various risk-reducing strategies that you can engage in. And what you've said about the younger women in that group who are mutation carriers are, in the 21st century, increasingly IT literate and will need that information online. No, so not boring patient leaflets that we've been doing for years and years. They want it at their fingertips now.